Good afternoon, everyone. Welcome to today's webinar presented by SAMHSA's GAIN Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is titled Fostering Trauma-Informed Practices in Your Courtroom, Approaches for Judges, Court Staff, and Providers. And the three presenters today are Dr. Lisa Callahan, Judge Marcia Hirsch, and Ms. Jennifer Johnson, and I will introduce them shortly. I am Erica Ihara. I am a project associate at SAMHSA's GAIN Center and Policy Research Associates. And before we start the presentations, I do have some housekeeping items. So the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or in regards to the technology, please use the Q&A pod on the right of your screen to type in your questions, and we will be addressing as many of your questions as possible at the end of the event as time permits. And we will also be conducting a couple of polls throughout the event, and we do appreciate your participation in these. So when you see a poll pop up, if you're able to participate, we do appreciate your input. This webinar is being recorded and slides will be disseminated via the GAIN's listserv following the webinar. We also will notify you when the webinar recording is posted to SAMHSA's YouTube channel. And finally, a certificate of attendance will be available for download at the end of the event. And please note, however, that this is for personal portfolio use only. It is not for CEU credits. We have arranged for ASL interpretation for this event. And so if you don't already have that visible on your screen, in order to view it, go to the layout in the upper right-hand corner of your screen, select Hide Non-Video Participants, and then change the layout to full screen, and then finally select View All. And we have two interpreters for today. Their names are Kelly Lan and Kip Opperman. There is also live captioning for this event. To view live captioning, select the Accept button in the Multimedia pod, which is in the lower right-hand corner of your screen. And the color contrast of the live caption pod can be changed as needed. So we do recommend high contrast style for best visibility. And next, I would like to introduce today's agenda. So coming up next, John Berg from SAMHSA will be giving some opening remarks, and then the presentations from Dr. Callahan, Judge Hirsch, and Ms. Johnson will follow. And for now, I would like to turn this over to John Berg. He is the Senior Public Health Advisor at the Center for Substance Abuse Treatment at SAMHSA. John, welcome.
Thank you so much, Erica. And welcome to today's webinar, Fostering Trauma-Informed Practices in Your Courtroom, Approaches for Judges, Court Staff, and Providers. We appreciate you taking time today to participate in today's informative webinar. SAMHSA endorses trauma-informed model of care. This model emphasizes the need for behavioral health practitioners and organizations to recognize the prevalence and pervasive impact of trauma on the lives of people they serve and develop trauma-sensitive or trauma-responsive services. The experience of trauma among people with substance abuse and mental health disorders, especially those involved with the criminal justice system, is so high as to be considered an almost universal experience. Trauma experiences affect the person's physical health, mental health, and ability to respond successfully to treatment and other interventions. The stress of the courtroom environment may also affect the ability of trauma survivors to communicate effectively with the judge and court personnel. Many judges have come to recognize that acknowledging and understanding the impact of trauma on court participants may lead to more successful interactions and outcomes. Trauma-informed courts acknowledge the prevalence of trauma among justice-involved people, as well as the risk for vicarious trauma among professionals working in these settings. This webinar will cover key concepts on the importance of adopting a trauma-informed approach in drug courts and provide practical information on how to implement trauma-informed practices. Today's presenters will share information on how to create trauma-informed drug court environments, screening and assessment for trauma, staff training, and developing policies that support a trauma-informed approach. Specific considerations for judges, treatment providers, and court staff will also be covered. We are pleased to have Jennifer Johnson, the Honorable Marcia Hirsch, and Dr. Lisa Callahan present on this very important topic. Thank you for taking time today to share your knowledge and expertise. I'd also like to take this time to thank the Gain Center and their staff for their work in developing and facilitating today's webinar. So at this time, I will turn it back to Erica.
Thank you, John. And now I would like to introduce our speakers to today's audience. So we have Dr. Lisa Callahan. She is Senior Research Associate at SAMHSA's Gain Center and Policy Research Associates. She works across multiple projects on topics including competence to stand trial, medication-assisted treatment, best practices for psychiatrists working with justice-involved people, assisted outpatient commitment, and treatment courts. And Dr. Callahan has worked on many projects with judges over the years, judges who preside over drug treatment courts, and she presents nationally on this topic. Judge Marcia Hirsch, she is the presiding judge of the Queens, New York Drug Treatment Court, which includes the DWI Treatment Court, the Mental Health Court, and the Veterans Court, as well as the Drug Diversion Court. She is also a consultant with SAMHSA's Gain Center, and Judge Hirsch lectures extensively on therapeutic justice, trauma-informed courts, and procedural justice, and she is the past president of the New York Association of Treatment Court Professionals. Ms. Jennifer Johnson is founder and principal of J.K. Johnson Advisors. She provides education, consulting, and technical assistance at the intersection of mental health and law. She worked for 20 years at the San Francisco Public Defender's Office, and she is one of the founders of San Francisco's Behavioral Health Court. And now I would like to take just a minute to review some of our poll results. So thank you to everyone who participated. So most of you today are joining from urban areas and followed next by rural areas. And the smallest group today is from suburban areas. So thank you all for joining us. And folks have also written in about their the areas that they work in. So we have many people from the judiciary, people from probation and parole, government, community-based organizations, and crisis service providers and academia. And did I catch everyone? And law enforcement. So thank you all for joining us. And now I will turn it over to Dr. Lisa Callahan.
Thank you, Erica, and thank you, John, for those words. Really well sets up the topic and the importance of the topic that we're going to be covering today. We have been looking at trauma and trauma-informed courts for a number of years at Policy Research Associates and at the Gain Center. And in fact, it was probably about 10 years ago when we began to work very directly with Judge Hirsch's courts, when we became first acquainted with her, because she really is one of the founding judges who has really brought trauma-informed practices to her court and has really served as a model for many judges who she has mentored. But one of the things that I think is indicative of the number of people who are enrolled in attending this webinar is that trauma has really become a focus across many systems, and especially in the criminal justice system. It's not just a fad. There are lots of very important reasons why trauma has become a focus, and not the least of which is the science has developed so much over the last decade or so in terms of our understanding not only of brain development, but also we've observed the impact of trauma on adults, whether it is emotional trauma or physical trauma. We've come to understand the impact that it can have, not just on someone's behavior, but also we're learning that it can actually change the DNA of people. So the science has really helped lead us to understand more about trauma. We also have come to understand that the systems that we've created over the last number of decades really are quite expensive. And by working in silos, not communicating, not collaborating, we've created a number of systems that really at times work at cross purposes for one another. so that by coming together as across systems and understanding how trauma really has such an impact across many systems and ultimately on the people we serve, it really has become a necessary conversation to have across the many systems, including the criminal justice system. And there's also the political reasons for focusing on trauma. We've certainly observed over the last 2 decades the impact of trauma on our soldiers who are returning from Afghanistan and Iraq and other places across the world, and serving them and understanding what they have experienced has become really a very important policy focus for us. It's important to also think about why it's important to become trauma informed, and we always like to make sure we make it personal for you and in your profession. We found that that organizations and courts and other practices such as probation who become trauma informed and really focus on trauma, really it increases safety, not just for the people we're serving, but also for your coworkers and for the environment that you work in and the communities. It's a way of promoting recovery and consequently public health. By being trauma informed, we can interrupt these sometimes maladaptive survival behavior patterns that people develop in response to trauma they've experienced. We ultimately, as professionals in the criminal justice system, certainly have the goal of reducing recidivism, and acknowledging trauma in our clients is important, but it's also important for us to acknowledge the trauma, both the primary trauma and secondary trauma that our colleagues experience, for us to be truly trauma informed and to reduce the burden on society. Our research and our work on trauma has been supported by SAMHSA for a number of decades. And so I want to read this SAMHSA's definition of trauma for you, because we refer to it as the 3 E's. It's an easy way to remember it, but individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. If you remember the 3 E's and keep in mind that for a bad event that's happened, for it to be trauma, for it to have a traumatic effect on someone, all 3 of these E's need to be present, because as we know, bad things happen to most everyone, and they don't all become traumatic because they don't have the same kind of lasting effect on us. So it's important to keep in mind that when we use the word trauma, we're talking about the event, the experience, and the long-term effects that it has on an individual. We're also going to talk about vicarious trauma, and that falls within within SAMHSA's definition. And sometimes it's referred to as secondary trauma. These are just some examples of the way in which secondary and vicarious trauma have been referred to in the literature. Really, the first person to really examine the concept of vicarious trauma was in 1982 with Figley, and he called it the cost of caring. And I think that sums it up well. The work that you do, especially for people who work in treatment courts, this isn't to say that all dockets aren't benefited by being trauma informed, but certainly by working in a drug court, you develop a relationship with your participants and one another. And rather than seeing someone for just a quick arraignment, et cetera, you really are with them. You live their lives with them for sometimes up to 2 years. And so you really care about them. And so when bad things happen to them or with them, it has an impact on you. And when you hear about what's happened to them, that emotional residue lingers, and it can cause symptoms of trauma very similar to as if you had experienced the trauma yourself. And so it's really important to be, if you're a trauma-informed court, you're not only tuned into primary trauma, but also to that secondary or vicarious trauma. Sometimes these 3 words or phrases are used interchangeably, and they really aren't the same thing. So burnout is really that physical or emotional exhaustion that most everyone experiences at some point in their job, whether it's paid employment or caring for family members. And this is really when you experience the demands on you being greater than the resources that you have. And so you develop burnout. But burnout can be addressed by having a better balance between the resources at hand and the demands that are putting on you. And I realize that's easier said than done. Compassion fatigue is this cumulative, it's really that cumulative emotional effect of exposure to trauma stories. When you work with people in that capacity, as all of you do who work in drug courts. Vicarious trauma, on the other hand, and this is really where it distinguishes from compassion fatigue, is there's a shift in the worldview. So it can grow out of compassion fatigue, especially if there's no intervention to help people address that trauma that they're hearing every day in their work. But vicarious trauma is when there is really a transformation that occurs. And if you think of that definition of the 3 E's, it is when now, not only have you observed in others those events, you've learned about their experiences, and the effects of that, those long-term effects start to affect you as well, in much the same way as if you had experienced it yourself. We know from the ACE studies, and just a quick reference to the ACE studies, these are the Adverse Childhood Experiences studies that were originally conducted by Kaiser Permanente in California, and now are maintained by the Centers for Disease Control. And what the ACE studies did was they surveyed adults who were in their healthcare system, the Kaiser Permanente healthcare system, to find out whether one of any of 10 events had happened to them before the age of 18. And the really important outcome of the ACEs studies, this is not a causal relationship, but what the ACEs studies have demonstrated is that exposure to childhood trauma significantly increases the risk of many physical health problems. And some of these may seem like, how could that be related to trauma? The ACE studies don't explain how it happens, but just that there is this relationship. And these really should be some red flags to you as you're learning more and more about the people who are your participants. If you see them having a lot of physical health problems, you can connect the dots and start to think that maybe this is a consequence of trauma that they experienced or are continuing to experience. We also know that there's a very strong connection between the ACEs, or childhood trauma, and also I would add adult trauma, but in the ACEs study demonstrate an increase in these behaviors as well: suicidality, alcohol misuse and abuse, et cetera, all that are listed here. So again, these may present themselves in your professional judgment as being measures or indicators of mental illness, but it's really important to think about how the symptoms of mental illness, which may lead to a particular diagnosis and a particular course of treatment, may in fact be arising from trauma rather than from an underlying mental illness. This isn't to say they aren't related, but when you put on your trauma-informed lens and you really closely examine, which you do have the opportunity to do in a drug court, it's important to know that some of those same symptoms overlap with mental illness. Most of you probably are very firmly aware of the fact that you do have an awful lot of people in your drug court who have co-occurring disorders. Sometimes it's referred to as comorbidity, but it is the coexistence of a mental health disorder and a substance use disorder. There's not a firm conclusion of whether or not exposure to trauma qualifies as that mental disorder in addition to the substance use disorder. But in practice, most behavioral health professionals who do work with this population recognize that the underlying trauma, such as even with or without a PTSD diagnosis and substance use disorder, are a very common co-occurrence. And there are a number of risk factors that people bring to your engagement with them that are going to be risk factors for developing co-occurring disorder. And these can be tricky for treating and addressing successfully in your drug court. So it's really important to know how trauma can be part of the underlying barriers, if you will. If the trauma is not being addressed, the underlying trauma can really be a barrier to someone making the kind of progress that you and they would like to see in the course of their drug court participation. Co-occurring disorders are extremely prevalent just in the general population. There are close to 8 million adults in the United States who have a co-occurring disorder. And in the justice system, of course, these numbers are even higher. We typically measure just for substance use disorder or mental illness when we're measuring how many people in our courts have one or the other, but recognize that many people, certainly in your court, whether or not they have a diagnosed co-occurring disorder, very likely do, especially if you include trauma as part of that diagnosis. Also, we know from SAMHSA's publications that most people do not receive treatment for their underlying mental illness or substance use disorder. So as people come into your court, especially if they're not known to you and you don't know whether they've gone to through a treatment court before, it's highly likely that they were not really deeply engaged in treatment prior to their admission to your court. So that's important to keep in mind. They may not be familiar with and have a habit of being engaged in treatment. So that's something to keep in mind when you, of course, treatment engagement is a really important component of drug courts. We know that there are many barriers to treatment, and this isn't just for people with co-occurring disorder, but also for people who have just, if I air quotes, just mental illness or just substance use disorder. But a majority of the people cite that they couldn't afford to get treatment. A lot of people also don't know where to go for treatment. And of course, there are a lot of people who think that they can handle whatever their problems are on their own. So in terms of focusing a little bit more now on vicarious trauma and compassion fatigue, keep in mind that there are cognitive symptoms, and these also are parallel to symptoms. If you experience primary trauma, you might be experiencing these in the secondary trauma because of the nature of the work that you're engaged in. And so just, kind of make a mental checklist of what these are. I'm not going to read them all to you because they're right here, but you might see these in the people who you're working with, and this might raise a red flag for you or some concerns. And you certainly will be seeing these symptoms in the people who you're working with in terms of the participants in your court. There are also emotional symptoms of vicarious trauma. And again, these are parallel to symptoms of primary trauma. And these, what we would encourage you to do is if you see your coworkers displaying some of these symptoms, to reach out to your human resources, or reach out to the judge would probably be the primary coworker who you would want to reach out to. That there may be coworkers who are suffering from vicarious trauma, or at least are having some issues dealing with the very difficult stories and difficult life challenges that your participants bring to you, and that you clearly are going to show empathy for. But it does have a toll, potentially has a toll. Remember that cost of caring that Figley called vicarious trauma. There are physical symptoms that also accompany vicarious trauma, just like primary trauma. Again, commit these to memory, or at least keep in mind that these symptoms might be something you observe in yourself or in your coworkers or others that you know who work with populations that have a lot of trauma and bring their stories to your court, and to be aware of them and to be on the lookout for all of those symptoms. So in asking who is at risk for developing vicarious trauma, the simple answer is absolutely everybody in your court. It isn't just the people who have the most direct interaction with your participants, but also others who are part of your court team. So it isn't just a matter of the people who are providing the behavioral health direct supports, but also be on the lookout for how the stories and the narratives and the experiences that your participants have on the bailiffs, on the court recorders, and on others who might not be directly on your radar because they're not as integral a part of your team as, say, the judge and the attorneys and your providers and peer specialists, and et cetera. There's been some research, and I do want to say here, just as a caveat, there is very little research on vicarious trauma among justice professionals. And I think that's a real gap in the research. Every year, I hope that there'll be a funding track from one of the federal funding agencies for research to address and to study vicarious trauma among treatment court professionals. But so far, we haven't seen that. But there has been some research done on judges on vicarious trauma. And I draw your attention to the second bullet here. A study that was done, it was reported in Judicature, a quarter of judges said that they miss 10 or more days of work due to stress. And stress is also another way of thinking about, it might not be full-blown vicarious trauma, but certainly is a precursor to trauma. Almost one half of the judges who responded to the question of the month in the National Judicial College newsletter said that almost half of them said that they had experienced vicarious trauma as a judge. There was a study recently done on judicial stress and resiliency, and it's really important to recognize that it isn't just judges who are in treatment courts who experience vicarious trauma or who run the risk of experiencing vicarious trauma, but there is this balancing of, sometimes it's referred to vicarious trauma and vicarious resilience, that on the one hand, you do get to know your participants in your court very well. You know about their families, you know about their experiences, you hear their stories, you develop a relationship with them and they with you, and there's some cost to that. At the same time, most treatment court judges, most drug court judges say it's the most rewarding part of their job. So there's this balance between vicarious trauma and vicarious resiliency that is really an important balance for you to be able to meet, so that you can not only do your best job, but also support the people who work with you and make sure they're experiencing that resiliency as well. Most of you are probably aware of the study that was done a few years ago by the American Bar Association and the Hazelden Foundation. And the main takeaway from that is that attorneys experience very high levels of depression, anxiety, and substance use, all of which are symptoms of vicarious trauma. This isn't to say that if you know an attorney or you are one who has depression, anxiety, or substance use, that is vicarious trauma, but it's a be on the lookout that may be underlying one of the causes, if you will, of the way of coping, such as using substances to cope with the trauma and the exhaustion from the work. A little bit of research has been done on probation officers. They also report high levels of trauma and stress related to their work. And these are all symptoms of trauma, and you can see the very high levels of experiencing these that the probation officers have endorsed. They feel, 3/4 of them feel desensitized. They feel cynical. They're suspicious of others. They're not tolerant. 2/3 have a distorted worldview. That's that transformation, right? That's that going from it being a bad experience to really having a long-term effect on you. And these, again, would be symptoms of vicarious trauma. We know that behavioral health providers in fact, there's been more research done on behavioral health providers and who are exposed to trauma as the result of their work. We know that as counselors and others who work with the drug treatment courts and other treatment courts, that the kinds of painful experiences and emotions that are provided by the clients who you work with do increase your risk of experiencing vicarious trauma. And it's this transformation that leads to a disruption in not only in your personal life, but also in the kind of work that you can do. And we always want to make sure that you're cautious and taking care to make those observations of yourself if possible. The 6 principles of a trauma-informed approach are presented here. These are SAMHSA's principles of trauma-informed approach. They include safety, and that is both emotional and physical safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural and historical and gender sensitivity. So these all together, not just one by itself, these are all part of the package of having a trauma-informed approach. It's important to, you could think of this as the 4 R's, that to become the steps to becoming a trauma-informed court. First, realize the prevalence of trauma and why a trauma-informed approach is important. Recognize how trauma affects individuals in an organization, program, system, and workforce. Respond effectively and with compassion, and resist re-traumatizing. The criminal justice system is in and of itself a traumatic experience for most people who are not the workers, but instead, if you would, the clients. And so the extent to which you can adapt your practices to avoid re-traumatization wherever possible is really important. So a trauma-informed practice would be to incorporate an understanding of trauma into your routine work practice. And that goes everyone from the judge to the receptionist. So thinking about what it is, be attuned to it, and just hardwire it into your routine. Make sure that the clients who come to your court, and in addition, their families and others who are associated with them, have access to trauma-informed interventions. And that's something that really the judge has a lot of leverage in making sure that trauma-informed providers are included in your list of behavioral health providers for your drug court. And in collaborating with those services in your community are really important. And make sure that you know what your partner organizations are providing, and are they providing trauma-informed practices. So keeping all of this in mind are really it's changing your paradigm in a way to make sure that trauma is, and whether your courtroom and your practices are in fact trauma-informed. So with that, I'm going to turn the presentation over to Judge Marcia Hirsch, and she'll give you some her vast experience with bringing trauma-informed practices to her courts in Queens.
Judge Hirsch, I think you're muted.
Can you hear me now?
Yep, we can hear you.
Okay, thank you. So I've been doing problem-solving courts now for 16 years, and we are passionate about the work that we do in providing trauma-informed services across all 5 of my treatment courts. Today, we will be looking at how do you identify trauma in your participants, how to adjust the relationships among the parties that you're working with, how to adapt the legal strategies. Again, authority here is not based on power, it's based on trust. And that's kind of the underlying theme of today's presentation. And Dr. Callahan just did an excellent job of talking about vicarious trauma and what to look out for with our very, very valuable team members and the treatment providers that we are working with. So our goal today is to give you practical strategies that you can bring back to your own court teams and courtrooms to start implementing many of them right away. Our court applied for and received a trauma grant back in 2009. We got a CSAT grant for 3 years. It covered us from 2010 to 2013 and enabled us to work with Policy Research Associates in developing our trauma screening, and 3 treatment providers in our community where their staff was trained in trauma-informed treatments. And we could then refer our participants to those treatment programs so that they could get the benefit of having trauma-informed services incorporated into their treatment plan. We think of trauma as the missing piece. After you deal with the participant's substance abuse issues and any mental health issues, I'm going to ask you to ask yourselves, what could be the impediment to some of our folks from achieving recovery and wellness? Oftentimes that is trauma. Identifying it and having our people learn to put it in context and deal with it and go forward so that they're not bogged down in that trauma, reliving and re-experiencing different phases of it. In preparing my talk today, I had to find that wonderful quote by our great American poet, Maya Angelou, who said, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." I love that quote, but I found another one that I think applies even more to what we're doing today. And that quote is, "There is no greater agony than bearing an untold story inside you." I think that really covers how a lot of our folks have experienced trauma in their lives, and it then becomes their untold story. So part of what we're going to talk about today is courtroom communication. And here on this screen, you see different examples of things that people say, like the professional's comment, "Your drug screen is dirty." And what the client thinks, "I'm dirty, there's something wrong with me." And the trauma-informed alternative, "Your drug screen shows the presence of drugs." Same thing with medication. We know medication can be a very, very sensitive issue with some of our participants. So if a judge were to ask, "Did you take your meds today?" The client's perception might be, "I'm a failure, I'm a bad person, nobody cares how these meds make me feel." So the trauma-informed alternative would be, are the meds your doctor prescribed working well for you? I also take that opportunity to ask my participants and to encourage them to talk to their doctor about any side effects that they're experiencing, or sometimes to discuss possible other medications that may work better for them with fewer side effects. This is all about empowering our participants to take part in their treatment. I love this next one. "You didn't follow the contract, you're going to jail. We're done with you. There is nothing more we can do." Oh, that's horrible. I really know that none of the judges who are on this call would ever say anything that insensitive to their participants, because the client's perception becomes, "I'm hopeless. Why do I care? Nobody else cares about me." So instead, the trauma-informed alternative says, maybe what we've been doing isn't the best way for us to support you. I'm going to ask you not to give up. We're not giving up on you. I also use that opportunity to say, when we're very frustrated, to actually ask the participant, "You seem to be struggling with your recovery. What do you need? What can we do to help you?" And usually they're the best person to give us some insight into what's going on with them and what do they need. Do they need more individual treatment? Do they need more groups? Do they need, would they like to talk to a peer? Sometimes they really do have the best insight. And then again, that very sensitive one, "I'm sending you for a mental health evaluation," which means, uh-oh, I must be crazy. There's something wrong with me. So the more trauma-informed alternative would be, "We're going to refer you to a doctor who can help us better understand how we can support you." Also, for my judges, there are some other helpful questions that you can ask for of your participants who you know have experienced trauma. One being, how have the traumas that you've experienced been triggers for use for you? Or do you have problems dealing with stress? What helps you deal with the stressors in your life? Or what things can you do to deal with feelings that you have that your trauma brings up? Again, it's a different way of approaching our participants' needs and figuring out how they can help build resilience and how they can put trauma in context in their own lives. So the SAMHSA guidelines for implementing a trauma-informed approach include these 5 areas, which we are going to go into now. With respect to screening, assessment, and treatment, I know Jennifer Johnson is going to cover this part in her presentation next, but I do want to throw out one caveat here that we learned very early in working with a population that has trauma. Everyone is not ready to discuss their trauma at the same time. You can't assume that a person who's just entering your drug court is right away going to be willing to talk about past trauma. Sometimes they have to be in recovery a little while. We call that having the fog and the haze of the drug or substance abuse issues lift. Sometimes their mental health has to be assessed and addressed there. Only then may they be ready to look at trauma. So when Jennifer goes through the different trauma screens, sometimes you may want to administer them in the beginning. And if you're not getting any response as far as the person identifying trauma, try it again. Try it maybe 3 months later or 6 months later when the person may be more receptive to talking about trauma and the experiences in their lives. Our treatment providers are currently using the Seeking Safety model and helping women and helping men in recovery and beyond trauma, the Dan Griffith's model of workbook manualized trauma treatments in their programs. With respect to monitoring and quality assurance, we always want to be sure that our programs are using evidence-based practices. We want to know, are people working the workbooks? What chapter are they up to? It's important to engage them when they come to court and see how they are progressing through the trauma modalities. With respect to financing, there are a lot of grants that are available out there right now. If you want to apply for an individual grant for your court, like we did with our court, or for any of you who are in statewide offices that govern problem-solving courts, you may want to apply for a statewide grant so that you could provide more trauma training for all of the courts in your jurisdictions. Then the last piece here being evaluation. We work with an evaluator from a local university, and this is important so that we know how is our trauma, how are our trauma services working, how are our people moving through the modalities, and how are they doing as far as our graduation rates go? Are people graduating successfully? Are people leaving treatment? Is the trauma treatment that they're getting helpful in their recovery? Leadership. What does it mean to provide leadership on the subject of a trauma-informed court? You need a champion for this approach. It oftentimes starts with the judge, and it spreads through the team. Every member must be on board. One person who is not on board with the trauma-informed approach can undo all of the efforts of the other team members. For a little while in my court, we had a clerk who was, I'll call her Debbie Downer. And it really reflected upon the rest of the team. And one person's insensitive words to our participant could really wreak havoc on weeks of trauma work that the person was doing in their trauma groups. So it's really important to train everyone on your team, and that does include your court officers, your bailiffs, probation, law enforcement. And you should also identify who's going to be responsible for this work. Is it your judge? Is it your court coordinator? And be sure that treatment is connected with you and that everyone is on the same page. We all now also want to include peers and persons with lived experience and be sure that they are trauma informed. Also, please take really, really good notes on the participants who appear in front of you. Be mindful of the anniversaries. Be mindful of the deaths of loved ones or serious illness in the family. It really means a lot when the person divulges to you last month that their mother was just diagnosed with colon cancer. And they come back and the first question you ask the next court date is, hey, how's your mother doing? And how are you doing? And do you have enough support and help to help take care of your mother? It just shows that you care about the person, you know that they're going through difficult situations, and you want to be mindful of that. Also, we've had participants on our court. The participants themselves have been diagnosed with cancer or have had heart attacks or strokes or broken bones. You want to ask about how they're doing, how their other medical treatment is going. You want to show that you care about the whole person, and you want them to do better, you want them to feel better, and you want them to have all the tools they need to live their best life. So show compassion, show concern. It costs us nothing to do that. My 3 rules I'll share with you because I remind myself of them every single day before I go on the bench. 1 being the Hippocratic Oath, do no harm. 2, I learned actually from a peer when I went to a training with judges and peers on trauma. And this peer stood up and looked at all the judges and she said, hey, just because you're a judge doesn't mean you have to be judgmental. I remind myself of that every single day. And the 3rd thing is to leave on a positive note. Even after the worst treatment update ever, leave on a positive note, even if it's saying to the person, you know, I know that this was a really rough report today and you have a lot of things you have to work on before the next court appearance, but I'm really looking forward to seeing you next week, next month, whatever, and having a good report at that time. Leave on a positive note, say something positive to the person so that they leave feeling a little bit better than they walked in to the courtroom. Look at your policies and your manual for your policy and procedures manual. Look at the material you give to your participants, analyze it, see if you're utilizing trauma-informed practices. If not, rewrite them. Develop your policies there to establish a trauma-informed approach. Be sure your treatment providers are also trauma-informed. For example, we had a program that used an old-fashioned TC model, and they bullied the participants. When we found that out, that they were bullying our participants, we stopped using that program. If they weren't going to change with the times, we were not sending our participants there. The trauma-informed approach has to be hardwired and run throughout your program. Keep an open door, open communication, be equally concerned for your staff and what's going on with them as well. I just want to give you another quick example of something that happened in my court 2 weeks ago. We had just put a young man in a residential treatment program, and he called after being there for 10 days, and he said, I'm not comfortable here because I found a homophobic slur written on the men's room wall, and I know it was directed at me. This was a young gay gentleman. So he let us know, he let his case manager know, he explained he was uncomfortable. We moved him. We found him another program, we moved him, we checked in with him to be sure that this new program was a better fit, and he was so much happier. He thanked us, and he's really moving forward well in the past couple of weeks since he changed programs. But that's just another example of how to be sensitive and caring and how to implement change quickly for the people that we deal with. Is your environment sensitive to trauma? I always tell, when I go out and do trainings, I tell my folks to walk through the space from the visitor's side. Go in through the front door, walk through, see what a person coming to your courtroom for the first time sees. Not from the court employee side. Is it welcoming? What does the signage look like? Are there lists of no's and don'ts? What's on your bulletin boards? Some judges have participants' artwork displayed. Some have different programs, different community opportunities for recreational, safe activities. Look what your participants are going to see when they come into your courtroom. Also, calendar management is really, really important and often overlooked when dealing with trauma. And this is another simple thing that you can really do based upon who's on your calendar that day and how what their different trauma experiences are. For example, in my mental health court, my court officer came up to me one day and he said, you know, Miss So-and-so is here today, and I noticed that she gets visibly upset and she trembles whenever we bring anyone from the pens, from the jail side, into the courtroom. Do you think there's a way we can handle her case first? We have several jail cases on today. So yeah, that was really easy to do. We took care of her case first, and any jail cases we handled in later. We also had a young man who had a long history of trauma, who was sexually abused by a rabbi in his Orthodox community. He did not want anyone clapping for him. And you know, in drug and treatment court, we clap for everything. He didn't want anyone clapping for him. He didn't want to get certificates. He wanted to be the last person called. So we would arrange our calendar there so that he could come in at the very end of the day when no one else was there. He was then more comfortable talking about his situations and speaking openly, and we were able to accommodate that in a trauma-informed setting. Your courtroom environment, the physical environment. If you do have that court officer who jingles the handcuffs behind the defendant, like where you're going in and you know what's going to happen here, that's not a trauma-informed approach. A trauma-informed approach would be the court officer calmly explaining what was going to happen and how the person was, if needed to go, the person needed to go into custody, that they would be handcuffed and where they would be going and what would be happening each step of the way, and not doing this by surprise. Again, I talked about the signs. Look at the signs that you have. Do you have the no eating, no newspaper reading, no cell phones, no? Look at the signage in your courtroom. You don't want people to feel intimidated or not respected or treated like children. With respect to the judge sitting behind the bench here, this is a personal preference, whatever the judge feels comfortable with. However, a judge can do things. I do sit behind the bench. I do not go down on the floor with my participants, but I will call participants up to the bench to discuss personal issues. Some of the personal issues that we've discussed at the bench are those serious diagnoses, for example, a cancer diagnosis. Miscarriage, abortion, pregnancy, those issues sometimes we would deal with at the bench if the person wants to talk about them with us in private. Another thing, when you have people that are anxious, when you call a bench conference without the defendant, explain to the defendant what you're talking about. We're going to take a break for a minute, Mr. or Miss So-and-so, and we're just going to be talking about your treatment plan at this time, and see if this is the best plan for you or if we need to tweak it a little. Explain what you're talking about so that they don't just say, oh, I must be in trouble, they're talking about me, this must be really bad. You want to reduce the level of anxiety in your participant. So engagement. How do you engage and involve others to foster it? Again, include your people in recovery, people receiving services, trauma survivors. Family members, be careful on family members and which family members you include. Some can be part of the problem, some can be part of the solution, some are supportive, some can be abusers. Be very, very careful and select the people who you think will best foster your participants' well-being. With your program design, again, be sure that your entire team knows what the treatment plan is, who's going to be responsible for delivering the services. Be sure that you're culturally competent. In Queens here, in Queens and New York City, we have people from 62 different countries who speak many, many different languages. Sometimes we need interpreters, we need programs that will provide treatment in a culturally competent setting. Be sure your staff is continually trained. Be sure there's new team member training whenever a new team member comes in and substitutes. There are excellent resources on the SAMHSA website, the Gain Center website, the NADCP and DCI websites, and also try to find mentors for new team members. Can you do this alone? No, it takes a village, it takes a courthouse, it takes a whole team. I know many of you are familiar with the SAMHSA's Gain Center sequential intercept model. Today we are looking at Intercepts 2 and 3, Intercept 4 with respect to reentry, and all of your community corrections and all of our connections there. I know that there's much more information about this, and you can do entire webinars on the sequential intercept model. So please do that. I encourage you to do that with your team. So recommendations for your stakeholders in your drug courts: communicate, talk to each other, do your check-in, as Dr. Callahan said, with your staff and with treatment. COVID's been very isolating for all of us. There have been many new challenges there. Check in, see how everybody's doing. We have stakeholder meetings in my court every 3 to 4 months with our community providers. We invite, in the past, before COVID, we invite everyone in to discuss issues. And this is another important fact that I wanted to point out. I came across this statistic from SAMHSA. In 2020, there was a 27% increase in calls to the SAMHSA website over the 2019 calls. So just think about that, 27% more calls in 1 year when COVID hit. We also know that overdose deaths on opiates are rising. So we have our work cut out for us. Ensure that all of your professionals have access to their own well-being resources and programs, whether it's employee assistance programs or whatever your human resources offers. Be sure there's adequate insurance, benefits, leave policies for our coworkers, and take a look at that caseload and the staffing studies. Use the evaluations to capture and analyze data. And thank you for your attention. I am now going to turn this over to Jennifer Johnson. Thank you.
Thank you, Judge Hirsch. And good afternoon, everybody. I'm going to get on to my first slide. So I'm going to be talking to you in a little more depth about screening and assessment, which might seem a little bit odd coming from a lawyer, but I think that it's important that it comes from a lawyer because I think that as criminal justice professionals across the sequential intercept model, I really think we have to be aware of what other people do. We need to know their work and their jobs and how that will impact our clients. So it does make sense in that respect. Why does this matter? Well, I can recall when I was in the mental health court in San Francisco, and I asked a clinician about a client in the jail, and I said, well, maybe he has trauma. And she said, everyone has trauma. I thought, oh, okay. That wasn't the right answer. Yes, everyone may have trauma, but unless we understand the individual aspects of that person's trauma, we're not going to create a treatment plan that works for that person. It's not going to work. So that's why we are going to talk a little bit about this screening and assessment. Integrated sort of mental health and substance use screening and assessment is the gold standard. There are high rates of mental health issues. And I think, as John said, which I really appreciate, we have come to learn that trauma is universal. If you checked how many ACEs your client had, or the person who's in front of you, if you're a judge, it's probably a lot. We're dealing with a highly traumatized population of people, and we presume trauma rather than looking for trauma at this point. It's not what we've always done, but it really is the best practice. You have to find it as early as you can. So we need to administer tools at the earliest possible point in the criminal justice system. When someone hits that system, we need to be doing a quality assessment. We also have to continue doing those assessments. People continue to experience trauma. The recency of trauma is often something that people in the criminal justice system will discuss. They have had it within the last 12 months. Also, people's mental health symptoms wax and wane over time, and they may have different needs at different times. So it has to be early. We have to screen often. We have to use measures that are consistent across the criminal justice system. That is important so that we're all working from the same information. I'll talk about that a little bit more when I get to the next slide. Also, we have to be able to communicate across intercepts, across systems. If we're not communicating what it is we know about a person, I understand that there are limitations in terms of personal health information, but we have to communicate with each other so that, again, we're all on the same page. If we're not going to create the proper individualized treatment plan for the person that is in front of us in a drug court. So these are SAMHSA's recommended screening instruments. And I think what this shows, this is only a fraction of screening instruments that exist, number one. I couldn't talk about all of them because we will be here till next Tuesday. But I want to just point out there are different screenings for mental health, substance use, co-occurring disorders, suicide risk. They're obviously overlapping to some degree, but this just points out that the complexity of the people that we are working with and that we are trying to put on a path to healing. I'm going to focus on the trauma history and PTSD column and go through a couple of these. Before I get to the next slide, I want to just point out, I'm going to talk about 3 of these, but I want to point out on the LCSR, the life stressor checklist. That is a, you can find all of these, or at least most of them, on the National Center for PTSD, which is a Veterans Administration website. The LCSR has particular questions that are related to women. And I think that's important to know if you are doing an assessment. They have questions about abortion, miscarriage, child separation, having an ill child. It is also, this screening also applies to men, but I just wanted to point out that there are some specific things for women embedded in that particular tool. So I want to just talk about a few of these. The life events checklist, the LEC5. The LEC5 is a self-report. It's got 16 or maybe the new one has 17 questions regarding potentially traumatic events: disaster, explosion, accident, assault with a weapon, sexual assault, among others. This tool was originally developed to be sort of a precursor or a pre-screening for the more robust, what they call CAPS, the Clinician Administered PTSD Scale. That is actually the gold standard for diagnosing post-traumatic stress disorder. This particular tool, it is often used in conjunction with other tools. That is the LEC5. Now, we also have the trauma history screen. Trauma history screen is 14 questions. It is also self-report, and it can be administered to a very wide population of people. The questions that are asked are: have you witnessed a really bad car, boat, train, or airplane accident, attacked with a knife, gun, or weapon, sudden death of a close family member, seeing someone die suddenly? Those are the types of questions. The other advantage of this particular instrument is that they use a common language and there are simple responses. So this can be administered across all education levels. Not all the tests have that advantage. So looking at, how did these things bother you emotionally? And then if yes, what are further questions that dive deeper into those particular events? Again, pointing out that, as Judge Hirsch did, not everybody is willing to or prepared to talk about trauma right when you might want them to, sometimes never, but we still, need to do these assessments. Post-traumatic checklist, the PCL5. This particular instrument is the PTSD checklist for the DSM-5. There are 5 questions about the worst event that's ever happened to you. How long ago? Did it involve actual threatened death, serious injury, or sexual violence? 20 items then ask about how that worst event bothered you in the last month. So even if it's 20 years ago, are you having repeated disturbing and unwanted memories of the experience, feeling distant or cut off from other people, being hypervigilant, super watchful? This particular instrument is good for monitoring symptom changes over time. So if you're looking about at that second bullet point, if it bothered you last week on one assessment, and then 6 months later, it didn't bother you at all, then that person is making progress. So as we said before, we need continuous assessment to observe those people who are healing or not healing. This test is good for also screening for PTSD and coming up with a provisional diagnosis. To come up with the gold standard diagnosis really is the CAPS, which is the clinician administered PTSD scale. That involves a structured interview with a clinician. And there are also other instruments as well. As I said, I can't possibly go through them all. And now I also want to talk about trauma-specific treatments. Judge Hirsch mentioned seeking safety, that they use seeking safety in her court. Seeking safety was developed primarily for women initially, but it is not a tool that is for women. One of the great things that we learned in my court when we got a grant for gender-specific treatment was that when we expected women to have higher rates of trauma, we actually found that men had equal rates of trauma. So it was very eye-opening for us. So seeking safety is for all genders. It's how to attain safety from trauma or addiction. And it's an integrated treatment with a flexible model. It can be individual or it can be group. I'm gonna go through these kind of quickly. This one, trauma-focused cognitive behavioral therapy. I think we've all probably heard of CBT as a treatment for people that works well for people in criminal justice. This particular one is focused on children and adolescents, their parents, and caregivers. It can identify single, multiple, or complex trauma. Next, we have Target. Trauma, this is a mouthful, Trauma Affect Regulation Guide for Education and Therapy. A target is the target population is for survivors of physical, sexual, psychological, and emotional abuse. It's from ages 10 to 18 plus for both men and women. A lot of times this test is given for single parents, children and caregivers, and foster kids and families. Next, the CPT for PTSD, cognitive processing therapy. Is effective for child abuse, combat, rape, natural disasters. It has a very wide range. And the other thing is that it's a 12-session module that's translated into 6 languages. That's something that, as Judge Hirsch also pointed out, we have people who have very different experience and come from different countries. So it's important that we're sensitive to that and we have some sense of cultural humility. Mission is another mouthful, maintaining independent sobriety through systems integration, outreach, and networking. This is for co-occurring disorders. There are a number of versions available for homelessness, for people who are criminal justice involved, for military veterans. So there's some choice in that one. Judge Hirsch also mentioned helping women and men in recovery and beyond trauma. These were originally for women. Judge mentioned, I think, Griffith. I would mention Stephanie Covington as one of the authors of these. And all of these tools you can find very, very easily online. They're downloadable, they're purchasable, they're very accessible. And I recommend looking at this at the Center for Gender and Justice. There are so many tools available there. And this is really about providing gender specific and gender responsive services. And it is, in fact, the Helping Men Recover program was the first gender responsive, trauma-informed treatment program for men. So it's looking at people individually. Again, I come back to this. Finally, we have EMDR, which is eye movement desensitization and processing. This is the one that's really brain focused. It's a psychotherapy method that looks to reconnect people to images, thoughts, emotions, body sensations, all of those things that Lisa talked about that are associated with a trauma. And then it's helping the brain engage its natural healing process. Our brains can heal, which is one of the hopeful things about this, about understanding people who have a trauma history, is that they can get better. This, essentially the trauma may be remembered, but that flight, right. I'm sure you know what I'm talking about. That is resolved. We don't engage our body in that fight, flight, or freeze. So Judge Hirsch, I keep referring back to you, but you mentioned so many things that are also on my mind. The entire workforce needs to be trained. If it's not, that's a link broken, and it can undo all the work that a community has done to create trauma-informed systems. I think about maybe the hardest job is the receptionist at the public defender's office. They deal with a lot of people face to face on the phone. They're the first line of communication. If they're not properly trained, then that's can be very destructive. So you could have your entire office trained, and if the receptionist at the desk is not trained, you're doing a disservice to the clients that you represent. Again, as we were saying, ongoing assessment is essential. There are a ton of evidence-based trauma-specific screenings. I laid out the ones that SAMHSA recommends. There's a wealth of information out there that's online, and you can get it very easily. The other thing is that there are financing structures that really are targeting trauma approaches. There's availability of technical assistance and training out there because there's such a recognition of the importance of this issue. And I think post-COVID, we haven't even really had a reckoning with COVID and the trauma that it's caused our country, our communities, our world, in fact. So I think it's going to be even more important and more accessible as we move forward. And just finally, Judge Hirsch went through some of these slides like this, but what is a trauma-informed approach? What I think I would ask you to look at these questions and think about how you could do something differently. I'm not going to necessarily answer them for you, but I will say that one of the keys to being trauma-informed is providing information to the people that don't know what is happening. Things happen in a courtroom. They happen quickly. It's callous. It is an environment where it in and of itself is traumatizing, but for people who have mental health and behavioral health issues, that can be even worse. So if you're handcuffing a defendant, how can a bailiff do that better? Can the lawyer explain that? What's happening? Can you ask, can I cuff you in front or can I cuff you in back? Which do you prefer? Giving people choice. If they're going to be going back to jail, how is that going to happen? Because it's a hugely traumatic event. And judges and lawyers can be sensitive to how their own behavior comes across in the courtroom, conducting a sidebar, whispering, those kind of things. They just foster a feeling of mistrust and mystery. And that's what we don't want. We want to demystify the courtroom and provide the people that are in there with the most information we can give them so that they can trust us and trust the process. So with that very quick rundown, I will hand this back to Erica.
Thank you. And I just wanted to take a moment before we move into the Q&A to thank all of our presenters today. So Ms. Johnson, Judge Hirsch, and Dr. Callahan, thank you so much for all of the information you shared and for sharing your expertise with everyone here. And we appreciate your time now as we move into the Q&A, just to take some time to address some questions from the audience. So for those of you who still have questions, if you haven't typed them in yet, please go ahead and type your questions into the Q&A pod. The first one I'm going to, I'll start with Judge Hirsch. So this is about virtual court hearings. In your opinion, do you feel, from what you've seen this past year with virtual court hearings, is that a helpful tool that can be helpful with traumatizing participants less?
Great question. Yes, I think it can be used. And I think it's been helpful during this time when we've been doing our calendars virtually for people who did not have to travel to the courthouse, people who could speak to us from the comfort of their own homes. I think people were more forthcoming and people really enjoyed speaking with us on the screen. I think they felt a little bit closer in a lot of ways than in the courtroom setting. And I know the therapists who I've spoken with also said that they thought their therapy sessions with their participants going virtually were going really, really well. And many people asked if they could continue doing virtual even after their offices reopened. Also, I know in one of my cases, I saw a veteran who was really struggling with breathing and he looked really sick to me on my screen. I encouraged him to go to the emergency room. He actually was diagnosed with COVID, was admitted, has recovered, went home, but he thanked me and said, I never would have gone if you didn't tell me. So he wouldn't have come to court in the old days if he felt poorly, but he would have just stayed home. So I think there is definitely a use for virtual going forward.
Thank you for that. And the next question I will just open up to whoever on the panel might want to speak about this. And it's a question about urine collection, observed urine collection. The person wanted to know, you know, is this something that can cause trauma, participating in observed urine collection? And so do you all have approaches that you've observed that you're aware of that might be less traumatic for somebody who is participating in that?
It's Judge Hirsch again. In my court, I know we've actually had this situation, and with some of our participants who've been sexually abused, we might allow them to have the oral mouth swabs done instead, or we've asked them how they would feel more comfortable, and we've taken our cues from them. So yes, we have adapted for those people who have been seriously traumatized in the past and are very resistant or reluctant to being tested for those reasons.
I would add also that that you can also narrate the process, because some things that we do in the system are uncomfortable, but they need to be done. And so providing an explanation of what's happening, how that's happening all along the way does help ease that process a bit.
And I was going to add, this is Lisa. I was going to add also to build on what both Judge Hirsch and Jennifer said. I think this goes across the board, not just for the observed urine test, but to say this is something that we have to do. It's part of the policies, and we have to. But is there someone among these 2 or 3 people that are permitted to do the observing, a probation officer, case manager, et cetera? Who would you feel most comfortable with, and giving them the choice of at least picking the person who is going to be with them.
That is very helpful. So the next question, I'm going to start with Ms. Johnson, and it's somebody in the audience would like to know, do you have any recommendations for like what the best approach for supporting professionals would be for people who are frequently losing participants due to accidental overdose?
You know, that's very interesting. I just wrote an article for the American Bar Association on the issue of suicide, and that the book is about suicide, and my piece was about why lawyers aren't prepared for it, because of all of those things that Lisa was talking about. These courts are, it's interesting. I've never heard of vicarious resiliency, but I think that's brilliant. And they definitely open us up to a lot more pain than we might get if we were practicing in a regular courtroom. That is undeniable. The thing about the court is, though, that it is a collaborative process. And I think drawing on your collaborative partners to find solutions to your how you process this information, I think is really important. We also, while we have, you know, access to clients who are going through things, we also have a team of people that are experienced and know how to help us. So I'm happy to answer more questions offline. I could talk too long about this issue, but I'm glad that Lisa covered it in such depth.
Thank you. And Dr. Callahan, I'm going to start with you for this next question. Do we know, like sort of national snapshot of approximately what percentage of treatment courts are currently using this trauma-informed approach?
No research has been done, but what I would say is that we have been doing presentations on trauma-informed courts at NADCP for the last number of years, and it's standing room only. And so if that's an indication of the interest, and certainly the number of people who are engaged in this webinar, I think that is a good indicator that people are interested. We certainly do a lot of training through the Gaines Center. We do a lot of training with drug courts and other courts and other parts of the justice system in terms of trauma-informed practices. But there is no survey or assessment, if you will, of how many courts are across the country actually are have implemented trauma-informed practices. But I am you know, I am optimistic when I see the amount of interest in the scope and the breadth of the professionals who are interested in this.
Thank you. And we are starting to close out the event. We've got about 6 minutes left. So I'm going to end with just one question for anyone on the panel who would like to speak to this, because I think there are multiple answers to this. So one of the people in the audience wanted to hear more about how these trauma-informed approaches can help with disparities in courts, disparities experienced by people of color and other marginalized individuals, you know, including considerations for systemic issues and also intergenerational issues. So I know that's a really broad question, but if anyone and if everyone on the panel would like to just say a couple of closing thoughts on that, I'll open it up to whoever wants to go first. Thank you.
This is Lisa. I'll go first, and I think that it's a very important question. And one suggestion I would make that that's a really big conversation to have is that in our training, when we do our trauma training with the justice professionals, we do spend a fair amount of time talking about historical and community trauma and really encouraging people to understand the communities and the cultures that their participants come from. And even though the ACE studies identified 10 events that might have happened in someone's life. They've actually expanded their understanding and their definitions of adversity to include circumstances and historical trauma. So I think that there is a greater conversation, even in the confines of the ACE research, which most people are familiar with. And I think it's something that I know that we really emphasize when we do our trauma training, is to make sure that you do your homework, you know, and to the extent you can learn secondhand about the experiences that people, not only what happened to them, but the world they were brought into, and the social and cultural and historical context is really, really important.
I want to answer that by saying two things. I think that trauma-informed approaches build trust. They build trust in the system because we're open, honest, and forthright. And a lot of people of color have not been treated that way by the criminal justice system. There's a tremendous amount of distrust. The second thing is that trauma-informed approaches are dignity-based. They are about imparting dignity and humanity on a group of people who often have not experienced that in criminal justice. It's a slowed down process that honors individual people. And I also think that people who have been, you know, marginalized in our society have had more experience of that in our very harsh criminal justice system.
All right, and with that, we are going to end the Q&A session. Once again, thank you to all of the speakers and to everyone in the audience today who has participated. You should have seen a file transfer box pop up on your screen, and this is for downloading these resources that you see on the slide here if you wish to download them. In addition to downloading a certificate, if you'd like to have that, just certifying that you attended today's event. So these are two resources from SAMHSA. You can also find them on the SAMHSA website. And one article, so just to remind everyone, the article all the way to the left of the screen on your slide, that is a hyperlink only. And when you receive the slides as a follow-up mailing, you can click the link and access the article that way. So you can, in the file transfer box, you can select any or all of the documents that you would like, and then just click the download button, and that will start the process for downloading those to your computer. And you'll also see the last poll for the day popping up. And so this is for you to put any additional input about TA or other areas that you would like related information. If you'd like to put your feedback there, we do share these data with SAMHSA. And I'd like to let you know about a couple of upcoming webinars that we have. On May 27th, that's tomorrow, we have a virtual learning community on medication-assisted treatment in drug courts, overcoming barriers to social integration for participants. In June, we have two webinars coming up. One is on teleservices and the future of teleservices in drug courts. And we also have an early diversion virtual learning community, and that's part 4 of a 5-part series. Registration for all of these events will be shared on the Gaines listserv. So if you are subscribed to the listserv, you will be seeing announcements about that coming in the coming weeks. If you have not signed up for the Gaines listserv, then I encourage you to do so. You can go to the link here on your computer and just type in your name, and that's all you need to do to sign up for to receive our announcements. And just here, I'd like to share some contact information about SAMHSA's Gaines Center. Please feel free to contact the Gaines Center if you have any other questions or comments for us, and you can feel free to reach us by email or by phone. So thanks everyone, and I hope you all have a wonderful afternoon.
Thank you.
I guess so.